Welcome to this video entitled, Drugs Used in Asthma. Asthma is characterized clinically by recurrent bouts of shortness of breath, chest tightness, and wheezing, often associated with coughing. Physiologically by widespread, reversible narrowing of the bronchial airways and a marked increase in bronchial responsiveness to inhaled stimuli, and pathologically by lymphocytic, eosinophilic inflammation of the bronchial mucosa. It is also characterized pathologically by remodeling of the bronchial mucosa, with thickening of the lamina reticularis beneath the airway epithelium and hyperplasia of the cells of all structural elements of the airway wall, that is vessels, smooth muscle, and secretory glands and goblet cells. In mild asthma, symptoms occur only occasionally, as on exposure to allergens or certain pollutants, on exercise, or after viral upper respiratory infection. More severe forms of asthma are associated with frequent attacks of wheezing dyspnea, especially at night, or with chronic airway narrowing, causing chronic respiratory impairment. These consequences of asthma are regarded as largely preventable, because effective treatments for relief of acute bronchoconstriction, using short-term relievers, and for reduction in symptoms and prevention of attacks, using long-term controllers, are available. The persistence of high medical costs for asthma care, driven largely by the costs of emergency department or hospital treatment of asthma exacerbations, are believed to reflect underutilization of the treatments available. The causes of airway narrowing in acute asthmatic attacks, or asthma exacerbations, include contraction of airway smooth muscle, inspissation of viscid mucus plugs in the airway lumen, and thickening of the bronchial mucosa from edema, cellular infiltration, and hyperplasia of secretory, vascular, and smooth muscle cells. Of these causes of airway obstruction, contraction of smooth muscle is most easily reversed by current therapy. Reversal of the edema and cellular infiltration requires sustained treatment with anti-inflammatory agents. Short-term relief is thus most effectively achieved by agents that relax airway smooth muscle, of which beta-adrenoceptor stimulants are the most effective and most widely used. Theophylline, a methylxanthine drug, and antimuscarinic agents are sometimes also used for reversal of airway constriction. Long-term control is most effectively achieved with an anti-inflammatory agent such as an inhaled corticosteroid. It can also be achieved, though less effectively, with a leukotriene pathway antagonist or an inhibitor of mast cell degranulation, such as cromolyn or nedocromil. Finally, clinical trials have established the efficacy of treatment for severe asthma with a humanized monoclonal antibody, omalizumab, which is specifically targeted against IgE, the antibody responsible for allergic sensitization. The distinction between short-term relievers and long-term controllers is blurred. Inhaled corticosteroids, regarded as long-term controllers, produce modest immediate bronchodilation. Theophylline, regarded as a bronchodilator, inhibits some lymphocyte functions and modestly reduces airway mucosal inflammation. Theophylline may also enhance the anti-inflammatory action of inhaled corticosteroids. This is also true of long-acting beta-adrenoceptor stimulants, like salmeterol and formoterol, which are effective in improving asthma control when added to inhaled corticosteroid treatment, though neither is anti-inflammatory when taken as a single agent. This chapter presents the basic pharmacology of the methylxanthines, cromolyn, leukotriene pathway inhibitors, and monoclonal anti-IgE antibody, agents whose medical use is almost exclusively for pulmonary disease. The other classes of drugs listed above are discussed in relation to the therapy of asthma. Pause the video and carefully scrutinize Figure 21, illustrating a conceptual model for the immunopathogenesis of asthma before advancing to the next slide. Next, W will look at pathogenesis of asthma. The classic immunologic model of asthma presents it as a disease mediated by rearginic immune globulin, IgE. Foreign materials that provoke IgE production are described as allergens. The most common are proteins from house dust mite, cockroach, animal danders, molds, and pollens. The tendency to produce IgE antibodies is genetically determined. Asthma and other allergic diseases cluster in families. Once produced, IgE antibodies bind to mast cells in the airway mucosa, as shown in Figure 21. On re-exposure to a specific allergen, antigen-antibody interaction on the surface of the mast cells triggers both the release of mediators stored in the cell's granules and the synthesis and release of other mediators. The histamine, tryptase, leukotrienes C4 and D4, and prostaglandin D2 that are released diffuse through the airway mucosa, triggering the muscle contraction and vascular leakage responsible for the acute bronchoconstriction of the early asthmatic response. This response is often followed in 3 to 6 hours by a second, more sustained phase of bronchoconstriction, the late asthmatic response, which is associated with an influx of inflammatory cells into the bronchial mucosa and with an increase in bronchial reactivity that may last for several weeks after a single inhalation of allergen. The mediators responsible for this late response are thought to be cytokines characteristically produced by Th2 lymphocytes, especially interleukins 5, 9, and 13. These cytokines are thought to attract and activate eosinophils, stimulate IgE production by B lymphocytes, and stimulate mucus production by bronchial epithelial cells. It is not clear whether lymphocytes or mast cells in the airway mucosa are the primary source of the mediators responsible for the late inflammatory response, but the benefits of corticosteroid therapy are attributed to their inhibition of the production of pro-inflammatory cytokines in the airways. The allergen challenge model does not reproduce all the features of asthma. Most asthma attacks are not triggered by inhalation of allergens. They are triggered by viral respiratory infection. Some adults with asthma have no evidence of allergic sensitivity to allergens, and even in people with allergic sensitivity, the severity of symptoms correlates poorly with levels of allergen in the atmosphere. Moreover, bronchospasm can be provoked by non-allergenic stimuli such as distilled water, exercise, cold air, sulfur dioxide, and rapid respiratory maneuvers. This tendency to develop bronchospasm on encountering stimuli that do not affect healthy non-asthmatic airways is characteristic of asthma and is sometimes called non-specific bronchial hyperreactivity, to distinguish it from bronchial responsiveness to specific antigens. Bronchial reactivity is assessed by measuring the fall in forced expiratory volume in 1 second, abbreviated as FEV1. Provoked by inhaling serially increasing concentrations of aerosolized methacholine. The exaggerated reactivity of the airways appears to be fundamental to asthma's pathogenesis, because it is nearly ubiquitous in patients with asthma and its degree roughly correlates with the clinical severity of the disease. The mechanisms underlying bronchial hyperreactivity are somehow related to inflammation of the airway mucosa. The agents that increase bronchial reactivity, such as ozone exposure, allergen inhalation, and infection with respiratory viruses, also cause airway inflammation. The increase in reactivity due to allergen inhalation is associated with an increase in both eosinophils and polymorphonuclear leukocytes in bronchial lavage fluid. The increase in reactivity that is associated with the late asthmatic response to allergen inhalation, as shown in Figure 21, is sustained and, because it is prevented by treatment with an inhaled corticosteroid, is thought to be caused by airway inflammation. Whatever the mechanisms responsible for bronchial hyperreactivity, bronchoconstriction itself seems to result not simply from the direct effect of the released mediators, but also from their activation of neural or humoral pathways. Evidence for the importance of neural pathways stems largely from studies of laboratory animals. The bronchospasm provoked in dogs by inhalation of histamine is reduced by pre-treatment with an inhaled topical anesthetic agent, by transection of the vagus nerves, and by pre-treatment with atropine. Studies of asthmatic humans, however, have shown that treatment with atropine causes only a reduction in, not abolition of, the bronchospastic responses to antigens and to non-antigenic stimuli. It is possible that activity in another neural pathway, such as the non-adrenergic, non-cholinergic system, contributes to bronchomotor responses to stimuli, as shown in Figure 22. The hypothesis suggested by these studies, that asthmatic bronchospasm results from a combination of release of mediators and an exaggeration of responsiveness to their effects, predicts that asthma may be effectively treated by drugs with different modes of action. Asthmatic bronchospasm might be reversed or prevented, for example, by drugs that reduce the amount of IgE bound to mast cells, anti-IgE antibody, prevent mast cell degranulation, such as cromolyn or nedocromil, sympathomimetic agents, calcium channel blockers, block the action of the products released, antihistamines and leukotriene receptor antagonists, inhibit the effect of acetylcholine released from vagal motor nerves, muscarinic antagonists, or directly relax airway smooth muscle, sympathomimetic agents, or theophylline. The second approach to the treatment of asthma is aimed not only at preventing or reversing acute bronchospasm but at reducing the level of bronchial responsiveness. Because increased responsiveness appears to be linked to airway inflammation and because airway inflammation is a feature of late asthmatic responses, this strategy is implemented both by reducing exposure to the allergens that provoke inflammation and by prolonged therapy with anti-inflammatory agents, especially inhaled corticosteroids. And now we will look at basic pharmacology of agents used in the treatment of asthma. The drugs most used for management of asthma are adrenoceptor agonists, or sympathomimetic agents, used as relievers, or bronchodilators, and inhaled corticosteroids, used as controllers, or anti-inflammatory agents. Their basic pharmacology is presented elsewhere. In this chapter, we review their pharmacology relevant to asthma. Pause the video and carefully scrutinize Figure 22 illustrating mechanisms of response to inhaled irritants before advancing to the next slide. We will now focus on sympathomimetic agents. The adrenoceptor agonists have several pharmacologic actions that are important in the treatment of asthma. They relax airway smooth muscle and inhibit release of bronchoconstricting mediators from mast cells. They may also inhibit microvascular leakage and increase mucociliary transport by increasing ciliary activity. As in other tissues, the beta agonists stimulate adenylyl cyclase and increase the formation of intracellular CAMP, as shown in Figure 23. The best characterized action of the adrenoceptor agonists in the airways is relaxation of airway smooth muscle. Although there is no evidence for direct sympathetic innervation of human airway smooth muscle, ample evidence exists for the presence of adrenoceptors on airway smooth muscle. In general, stimulation of beta-2 receptors relaxes airway smooth muscle, inhibits mediator release, and causes tachycardia and skeletal muscle tremor as side effects. The sympathomimetic agents that have been widely used in the treatment of asthma include epinephrine, ephedrine, isoproterenol, and albuterol and other beta-2 selective agents, as shown in Figure 24. Because epinephrine and isoproterenol increase the rate and force of cardiac contraction, mediated mainly by beta-1 receptors, they are reserved for special situations, see below. In general, adrenoceptor agonists are best delivered by inhalation, because this results in the greatest local effect on airway smooth muscle with the least systemic toxicity. Aerosol deposition depends on the particle size, the pattern of breathing, and the geometry of the airways. Even with particles in the optimal size range of 2 to 5 mm, 80 to 90% of the total dose of aerosol is deposited in the mouth or pharynx. Particles under 1 to 2 micrometers remain suspended and may be exhaled. Bronchial deposition of an aerosol is increased by slow inhalation of a nearly full breath and by more than 5 seconds of breath holding at the end of inspiration. Epinephrine is an effective, rapidly acting bronchodilator when injected subcutaneously, that is 0.4 ml of 1 to 1000 solution, or inhaled as a microaerosol from a pressurized canister, that is 320 micrograms per puff. Maximal bronchodilation is achieved 15 minutes after inhalation and lasts 60 to 90 minutes. Because epinephrine stimulates alpha and beta-1 as well as beta-2 receptors, tachycardia, arrhythmias, and worsening of angina pectoris are troublesome adverse effects. The cardiovascular effects of epinephrine are of value for treating the acute vasodilation and shock as well as the bronchospasm of anaphylaxis, but its use in asthma has been displaced by other, more beta-2 selective agents. Ephedrine was used in China for more than 2,000 years before its introduction into Western medicine in 1924. Compared with epinephrine, ephedrine has a longer duration, oral activity, more pronounced central effects, and much lower potency. Because of the development of more efficacious and beta-2 selective agonists, ephedrine is now used infrequently in treating asthma. Isoproterenol is a potent bronchodilator. When inhaled as a microaerosol from a pressurized canister, 80 to 120 micrograms isoproterenol causes maximal bronchodilation within 5 minutes. Isoproterenol has a 60 to 90 minute duration of action. An increase in the asthma mortality rate that occurred in the United Kingdom in the mid-1960s was attributed to cardiac arrhythmias resulting from the use of high doses of inhaled isoproterenol. It is now rarely used for asthma. Pause the video and carefully scrutinize Figure 23 illustrating bronchodilation is promoted by cyclic AMP before advancing to the next slide. We will now look at beta-2 selective drugs. The beta-2 selective adrenoceptor agonist drugs, particularly albuterol, are the most widely used sympathomimetics for the treatment of the bronchoconstriction of asthma at present, as shown in Figure 24. These agents differ structurally from epinephrine in having a larger substitution on the amino group and in the position of the hydroxyl groups on the aromatic ring. They are effective after inhaled or oral administration and have a long duration of action. Albuterol, terbutaline, metoprolol, and perbuterol are available as metered dose inhalers. Given by inhalation, these agents cause bronchodilation equivalent to that produced by isoproterenol. Bronchodilation is maximal within 15 to 30 minutes and persists for 3 to 4 hours. All can be diluted in saline for administration from a handheld nebulizer. Because the particles generated by a nebulizer are much larger than those from a metered dose inhaler, much higher doses must be given, that is 2.5 to 5.0 mg vs 100 to 400 micrograms, but are no more effective. Nebulized therapy should thus be reserved for patients unable to coordinate inhalation from a metered dose inhaler. Most preparations of beta-2 selective drugs are a mixture of R and S isomers. Only the R isomer activates the beta agonist receptor. Reasoning that the S isomer may promote inflammation, a purified preparation of the R isomer of albuterol has been developed, also called levalbuterol. Whether this actually presents significant advantages in clinical use is unproven. Albuterol and terbutaline are also available in tablet form. One tablet 2 or 3 times daily is the usual regimen. The principal adverse effects of skeletal muscle tremor, nervousness, and occasional weakness may be reduced by starting the patient on half-strength tablets for the first 2 weeks of therapy. This route of administration presents no advantage over inhaled treatment and is thus rarely prescribed. Of these agents, only terbutaline is available for subcutaneous injection, of 0.25 mg. The indications for this route are similar to those for subcutaneous epinephrine, severe asthma requiring emergency treatment when aerosolized therapy is not available or has been ineffective. But it should be remembered that terbutaline's longer duration of action means that cumulative effects may be seen after repeated injections. A new generation of long-acting beta-2 selective agonists includes salmeterol, a partial agonist, and formoterol, a full agonist. Both drugs are potent selective beta-2 agonists that achieve their long duration of action, 12 hours or more, as a result of high lipid solubility. This permits them to dissolve in the smooth muscle cell membrane in high concentrations or, possibly, attach to murin molecules in the vicinity of the adrenoceptor. These drugs appear to interact with inhaled corticosteroids to improve asthma control. Because they have no anti-inflammatory action, they are not recommended as monotherapy for asthma. An ultra-long-acting beta agonist, indacaterol, is currently approved in Europe. It needs to be taken only once a day, but is used only for the treatment of chronic obstructive pulmonary disease, abbreviated as COPD. Data on its efficacy and safety in management of asthma are lacking. Pause the video and carefully scrutinize Figure 24 illustrating the structures of isoprotronol and several beta-2 selective analogues before advancing to the next slide. Next we will discuss toxicities. The use of sympathomimetic agents by inhalation at first raised fears about possible cardiac arrhythmias and about hypoxemia acutely and tachyphylaxis or tolerance when given repeatedly. It is true that the vasodilating action of beta-2 agonist treatment may increase perfusion of poorly ventilated lung units, transiently decreasing arterial oxygen tension, abbreviated as PaO2. This effect is usually small, however, and may occur with any bronchodilator drug. The significance of such an effect depends on the initial arterial oxygen tension of the patient. Administration of supplemental oxygen, routine in treatment of an acute severe attack of asthma, eliminates any concern over this effect. The other concern, that customary doses of beta-agonist treatment may cause lethal cardiac arrhythmias, appears unsubstantiated. In patients presenting for emergency treatment of severe asthma, irregularities in cardiac rhythm improve with the improvements in gas exchange affected by bronchodilator treatment and oxygen administration. The concept that beta-agonist drugs worsen clinical asthma by inducing tachyphylaxis to their own action has not been established. Most studies have shown only a small change in the bronchodilator response to beta stimulation after prolonged treatment with beta agonist drugs, but some studies have shown a loss in the ability of beta agonist treatment to inhibit the response to subsequent challenge with exercise, methacholine, or antigen challenge, referred to as a loss of bronchoprotective action. Although it is true that beta-2 adrenoceptor agonists appear to be safe and effective bronchodilators when taken on an, as needed, basis for relief of symptoms, there is some evidence of risk of adverse effects from chronic treatment with long-acting beta agonists. These risks were suspected to be greater for individuals carrying a genetic variant for the beta receptor, specifically at the B16 locus of the beta receptor. Retrospective analyses of studies of regular treatment with an inhaled beta agonist suggested that asthma control deteriorated among patients homozygous for arginine at this locus, a genotype found in 16% of the Caucasian population and more commonly in African Americans in the USA. It was thus tempting to speculate that a genetic variant may underlie the report of an increase in asthma mortality from regular use of a long-acting beta agonist in studies involving very large numbers of patients. See below. But it should be noted that only trivial differences were observed in multiple measures of asthma control in a study comparing patients with the ARG or GLI genotypes treated with salmeterol in combination with an inhaled corticosteroid. While studies so far have failed to prove that genetic variations at this particular site in the gene for the beta receptor are related to adverse responses to prolonged beta agonist treatment, pharmacogenetic studies of asthma treatment will continue to be an active focus of research, as an approach to the development of personalized therapy for asthma and other diseases. Next we will discuss methylxanthine drugs. The three important methylxanthines are theophylline, theobromine, and caffeine. Their major source is beverages, such as tea, cocoa, and coffee, respectively. The importance of theophylline as a therapeutic agent in the treatment of asthma has waned as the greater effectiveness of inhaled adrenoceptor agents for acute asthma and of inhaled anti-inflammatory agents for chronic asthma has been established. But theophyline's very low cost is an important advantage for economically disadvantaged patients in societies in which healthcare resources are limited. Next W will discuss the chemistry methylxanthine drugs. As shown below, theophylline is 1,3-dimethylxanthine, theobromine is 3,7-dimethylxanthine, and caffeine is 1,3,7-trimethylxanthine. A theophylline preparation commonly used for therapeutic purposes is aminophyline, a theophylline ethylene diamine complex. The pharmacokinetics of theophylline are discussed below. See clinical uses of methylxanthines. The metabolic products, partially demethylated xanthines, not uric acid, are excreted in the urine. Pause the video and carefully scrutinize the white box containing their structures before advancing to the next slide. And now let's look at their mechanism of action. Several mechanisms have been proposed for the actions of methylxanthines, but none has been firmly established. At high concentrations, they can be shown in vitro to inhibit several members of the phosphodiesterase (PDE) enzyme family, as shown in Figure 20-3. Because the phosphodiesterase hydrolyze cyclic nucleotides, this inhibition results in higher concentrations of intracellular cyclic AMP and, in some tissues, cyclic GMP. Cyclic AMP is responsible for a myriad of cellular functions including, but not limited to, stimulation of cardiac function, relaxation of smooth muscle, and reduction in the immune and inflammatory activity of specific cells. Of the various isoforms of phosphodiesterase that have been identified, PDE4 appears to be the most directly involved in actions of methylxanthines on airway smooth muscle and on inflammatory cells. The inhibition of PDE4 in inflammatory cells reduces their release of cytokines and chemokines, which in turn results in a decrease in immune cell migration and activation. In an effort to reduce toxicity while maintaining therapeutic efficacy, selective inhibitors of different isoforms of PDE4 were developed. Many were abandoned after clinical trials showed that their toxicities of nausea, headache, and diarrhea restricted dosing to subtherapeutic levels, but one, roflumilast, has recently been approved by the Food and Drug Administration, FDA, as a treatment for chronic obstructive pulmonary disease, though not for asthma. Another proposed mechanism is inhibition of cell surface receptors for adenosine. These receptors modulate adenylyl cyclase activity, and adenosine has been shown to provoke contraction of isolated airway smooth muscle and histamine release from airway mast cells. It has been shown, however, that xanthine derivatives devoid of adenosine antagonism, e.g., enprofuthlin, may be potent in inhibiting bronchoconstriction in asthmatic subjects. Some research suggests that the efficacy of theophyllenes may be due to a third mechanism of action: enhancement of histone deacetylation. Acetylation of core histones is necessary for activation of inflammatory gene transcription. Corticosteroids act, at least in part, by recruiting histone deacetylactylases to the site of inflammatory gene transcription, an action enhanced by low-dose theophylline. This interaction should predict that low-dose theophylline treatment would enhance the effectiveness of corticosteroid treatment, and some clinical trials indeed support the idea that theophylline treatment is effective in restoring corticosteroid responsiveness in asthmatics who smoke and in patients with some forms of chronic obstructive pulmonary disease. We will now discuss the pharmacodynamics of methylxanthanes. The methylxanthanes have effects on the central nervous system, kidney, and cardiac and skeletal muscle as well as smooth muscle. Of the three agents, theophylline is most selective in its smooth muscle effects, whereas caffeine has the most marked central nervous system effects. We will now focus on central nervous system effects. In low and moderate doses, the methylxanthanes, especially caffeine, cause mild cortical arousal with increased alertness and deferral of fatigue. The caffeine contained in beverages, e.g., 100 mg in a cup of coffee, is sufficient to cause nervousness and insomnia in sensitive individuals and slight bronchodilation in patients with asthma. The larger doses necessary for more effective bronchodilation commonly cause nervousness and tremor in some patients. Very high doses, from accidental or suicidal overdose, cause medullary stimulation and convulsions and may lead to death. Next we will discuss the cardiovascular effects of methylxanthanes. The methylxanthanes have positive chronotropic and inotropic effects. At low concentrations, these effects appear to result from inhibition of presynaptic adenosine receptors in sympathetic nerves, increasing catecholamine release at nerve endings. The higher concentrations, that is greater than 10 micromoles per liter, that is 2 mg per liter, associated with inhibition of phosphodiesterase and increases in cyclic AMP may result in increased influx of calcium. At much higher concentrations, that is greater than 100 micromoles per liter, sequestration of calcium by the sarcoplasmic reticulum is impaired. The clinical expression of these effects on cardiovascular function varies among individuals. Ordinary consumption of coffee and other methylxanthine-containing beverages usually produces slight tachycardia, an increase in cardiac output, and an increase in peripheral resistance, raising blood pressure slightly. In sensitive individuals, consumption of a few cups of coffee may result in arrhythmias. In large doses, these agents also relax vascular smooth muscle except in cerebral blood vessels, where they cause contraction. Methylxanthanes decrease blood viscosity and may improve blood flow under certain conditions. The mechanism of this action is not well defined, but the effect is exploited in the treatment of intermittent claudication with pentoxaphylline, a dimethylxanthone agent. However, no evidence suggests that this therapy is superior to other approaches. Next we will discuss effects of methylxanthanes on the gastrointestinal tract. The methylxanthanes stimulate secretion of both gastric acid and digestive enzymes. However, even decaffeinated coffee has a potent stimulant effect on secretion, which means that the primary secretagogue in coffee is not caffeine. And now let's consider the effects of methylxanthanes on kidney. The methylxanthanes, especially theophylline, are weak diuretics. This effect may involve both increased glomerular filtration and reduced tubular sodium reabsorption. The diuresis is not of sufficient magnitude to be therapeutically useful. We will now focus on the effects of methylxanthanes on smooth muscle. The bronchodilation produced by the methylxanthanes is the major therapeutic action in asthma. Tolerance does not develop, but adverse effects, especially in the central nervous system, may limit the dose. See below. In addition to their effect on airway smooth muscle, these agents, in sufficient concentration, inhibit antigen-induced release of histamine from lung tissue. Their effect on mucociliary transport is unknown. And now we will consider the effects of methylxanthanes on skeletal muscle. The respiratory actions of the methylxanthanes may not be confined to the airways, for they also strengthen the contractions of isolated skeletal muscle in vitro and improve contractility and reverse fatigue of the diaphragm in patients with chronic obstructive pulmonary disease. This effect on diaphragmatic performance, rather than an effect on the respiratory center, may account for theophyline's ability to improve the ventilatory response to hypoxia and to diminish dyspnea even in patients with irreversible airflow obstruction. We will now consider the clinical uses of xanthanes. Of the xanthanes, theophylline is the most effective bronchodilator, and it has been shown repeatedly both to relieve airflow obstruction in acute asthma and to reduce the severity of symptoms and time lost from work or school in patients with chronic asthma. Theophylline base is only slightly soluble in water, so it has been administered as several salts containing varying amounts of theophylline base. Most preparations are well absorbed from the gastrointestinal tract, but absorption of rectal suppositories is unreliable. Improvements in theophylline preparations have come from alterations in the physical state of the drugs rather than from new chemical formulations. For example, the increased surface area of anhydrous theophylline in a microcrystalline form facilitates solubilization for complete and rapid absorption after oral administration. Numerous sustained-release preparations are available and can produce therapeutic blood levels for 12 hours or more. These preparations offer the advantages of less frequent drug administration, less fluctuation of theophylline blood levels, and, in many cases, more effective treatment of nocturnal bronchospasm. Theophylline should be used only where methods to measure theophylline blood levels are available because it has a narrow therapeutic window, and its therapeutic and toxic effects are related to its blood level. Improvement in pulmonary function is correlated with plasma concentration in the range of 5 to 20 mg per liter. Anorexia, nausea, vomiting, abdominal discomfort, headache, and anxiety occur at concentrations of 15 mg per liter in some patients and become common at concentrations greater than 20 mg per liter. Higher levels, that is greater than 40 mg per liter, may cause seizures or arrhythmias. These may not be preceded by gastrointestinal or neurologic warning symptoms. The plasma clearance of theophylline varies widely. Theophylline is metabolized by the liver, so usual doses may lead to toxic concentrations of the drug in patients with liver disease. Conversely, clearance may be increased through the induction of hepatic enzymes by cigarette smoking or by changes in diet. In normal adults, the mean plasma clearance is 0.69 ml per kilogram per minute. Children clear theophylline faster than adults, that is 1 to 1.5 ml per kilogram per minute. Neonates and young infants have the slowest clearance. Even when maintenance doses are altered to correct for the above factors, plasma concentrations vary widely. Theophylline improves long-term control of asthma when taken as the sole maintenance treatment or when added to inhaled corticosteroids. It is inexpensive, and it can be taken orally. Its use, however, also requires occasional measurement of plasma levels. It often causes unpleasant minor side effects, especially insomnia, and accidental or intentional overdose can result in severe toxicity or death. For oral therapy with the prompt-release formulation, the usual dose is 3 to 4 mg per kilogram of theophylline every 6 hours. Changes in dosage result in a new steady-state concentration of theophylline in 1 to 2 days, so the dosage may be increased at intervals of 2 to 3 days until therapeutic plasma concentrations are achieved, that is 10 to 20 mg per liter, or until adverse effects develop. Next we will discuss antimuscarinic agents. Observation of the use of leaves from Datura stramonium for asthma treatment in India led to the discovery of atropine, a potent competitive inhibitor of acetylcholine at postganglionic muscarinic receptors, as a bronchodilator. Interest in the potential value of antimuscarinic agents increased with demonstration of the importance of the vagus nerves in bronchospastic responses of laboratory animals and with the development of a potent atropine analog that is poorly absorbed after aerosol administration and is therefore relatively free of systemic atropine-like effects. We will now discuss the mechanism of action of muscarinic antagonists. Muscarinic antagonists competitively inhibit the effect of acetylcholine at muscarinic receptors. In the airways, acetylcholine is released from efferent endings of the vagus nerves, and muscarinic antagonists block the contraction of airway smooth muscle and the increase in secretion of mucus that occurs in response to vagal activity, as shown in Figure 22. Very high concentrations, well above those achieved even with maximal therapy, are required to inhibit the response of airway smooth muscle to non-muscarinic stimulation. This selectivity of muscarinic antagonists accounts for their usefulness as investigative tools in examining the role of parasympathetic pathways in bronchomotor responses, but limits their usefulness in preventing bronchospasm. In the doses given, antimuscarinic agents inhibit only that portion of the response mediated by muscarinic receptors, which varies by stimulus, and which further appears to vary among individual responses to the same stimulus. We will now focus on the clinical uses of antimuscarinic agents. Antimuscarinic agents are effective bronchodilators. When given intravenously, atropine, the prototypical muscarinic antagonist, causes bronchodilation at a lower dose than that needed to cause an increase in heart rate. The selectivity of atropine's effect can be increased further by administering the drug by inhalation or by use of a more selective quaternary ammonium derivative of atropine, ipratropium bromide. Ipratropium can be delivered in high doses by this route because it is poorly absorbed into the circulation and does not readily enter the central nervous system. Studies with this agent have shown that the degree of involvement of parasympathetic pathways in bronchomotor responses varies among subjects. In some, bronchoconstriction is inhibited effectively. In others, only modestly. The failure of higher doses of the muscarinic antagonist to further inhibit the response in these individuals indicates that mechanisms other than parasympathetic reflex pathways must be involved. Even in the subjects least protected by this antimuscarinic agent, however, the bronchodilation and partial inhibition of provoked bronchoconstriction are of potential clinical value, and antimuscarinic agents are valuable for patients intolerant of inhaled beta-agonist agents. Although antimuscarinic drugs appear to be slightly less effective than beta-agonist agents in reversing asthmatic bronchospasm, the addition of ipratropium enhances the bronchodilation produced by nebulized albuterol in acute severe asthma. Ipratropium appears to be at least as effective in patients with chronic obstructive pulmonary disease that includes a partially reversible component. A longer-acting, selective antimuscarinic agent, tiotropium, is approved as a treatment for chronic obstructive pulmonary disease. It binds to M1, M2, and M3 receptors with equal affinity, but dissociates most rapidly from M2 receptors, expressed on the efferent nerve ending. This means that tiotropium does not inhibit the M2 receptor-mediated auto-down-regulation of acetylcholine release, and thus confers a degree of receptor selectivity. Tiotropium is also taken by inhalation, and a single dose of 18 micrograms has 24-hour duration of action. Daily inhalation of tiotropium has been shown not only to improve functional capacity of patients with chronic obstructive pulmonary disease, but also to reduce the frequency of exacerbations of their condition, and tiotropium is approved by the FDA as a treatment for chronic obstructive pulmonary disease. It has not been approved as a treatment for asthma, but the addition of tiotropium has recently been shown to be as effective as the addition of a long-acting beta-agonist in asthmatic patients insufficiently controlled by inhaled corticosteroid therapy alone. We will now progress to corticosteroids. Let's begin with their mechanism of action. Corticosteroids have been used to treat asthma since 1950 and are presumed to act by their broad anti-inflammatory efficacy, mediated in part by inhibition of production of inflammatory cytokines. They do not relax airway smooth muscle directly, but reduce bronchial reactivity and reduce the frequency of asthma exacerbations if taken regularly. Their effect on airway obstruction may be due in part to their contraction of engorged vessels in the bronchial mucosa and their potentiation of the effects of beta receptor agonists, but their most important action is inhibition of the infiltration of asthmatic airways by lymphocytes, eosinophils, and mast cells. We will now consider the clinical uses of corticosteroids. Clinical studies of corticosteroids consistently show them to be effective in improving all indices of asthma control, severity of symptoms, tests of airway caliber and bronchial reactivity, frequency of exacerbations, and quality of life. Because of severe adverse effects when given chronically, oral and parenteral corticosteroids are reserved for patients who require urgent treatment, i.e., those who have not improved adequately with bronchodilators or who experience worsening symptoms despite maintenance therapy. Regular or controller therapy is maintained with aerosol corticosteroids. Urgent treatment is often begun with an oral dose of 30 to 60 mg of prednisone per day or an intravenous dose of 1 mg per kilogram methylprednisolone every 6 to 12 hours. The daily dose is decreased after airway obstruction has improved. In most patients, systemic corticosteroid therapy can be discontinued in 7 to 10 days. But in other patients symptoms may worsen as the dose is decreased to lower levels. Because adrenal suppression by corticosteroids is related to dose and because secretion of endogenous corticosteroids has a diurnal variation, it is customary to administer corticosteroids early in the morning after endogenous adrenocorticotropic hormone secretion has peaked. For prevention of nocturnal asthma, however, oral or inhaled corticosteroids are most effective when given in the late afternoon. Aerosol treatment is the most effective way to avoid the systemic adverse effects of corticosteroid therapy. The introduction of corticosteroids such as beclomethasone, budesonide, C-clesonide, flunisolide, fluticasone, mometasone, and triamcinolone has made it possible to deliver corticosteroids to the airways with minimal systemic absorption. An average daily dose of 4 puffs twice daily of beclomethasone, 400 micrograms per day, is equivalent to about 10 to 15 milligrams per day of oral prednisone for the control of asthma, with far fewer systemic effects. Indeed, one of the cautions in switching patients from oral to inhaled corticosteroid therapy is to taper oral therapy slowly to avoid precipitation of adrenal insufficiency. In patients requiring continued prednisone treatment despite inhalation of standard doses of an aerosol corticosteroid, higher doses appear to be more effective. Inhalation of high doses of both fluticasone and C-clesonide, for example, have been shown to be effective in weaning patients from chronic prednisone therapy. Although these high doses of inhaled steroids may cause adrenal suppression, the risks of systemic toxicity from chronic use appear negligible compared with those of the oral corticosteroid therapy they replace. A special problem caused by inhaled topical corticosteroids is the occurrence of oropharyngeal candidiasis. The risk of this complication can be reduced by having patients gargle water and spit after each inhaled treatment. Hoarseness can also result from a direct local effect of inhaled corticosteroids on the vocal cords. These agents are remarkably free of other short-term complications in adults, but may increase the risks of osteoporosis and cataracts over the long term. In children, inhaled corticosteroid therapy has been shown to slow the rate of growth by about 1 centimeter over the first year of treatment, but not the rate of growth thereafter, so that the effect on adult height is minimal. A novel approach to minimizing the risk of toxicity from systemic absorption of an inhaled corticosteroid underlay the development of C-clesonide. This recently approved corticosteroid is inhaled as a pro-drug activated by cleavage by esterases in bronchial epithelial cells. When absorbed into the circulation, the active product is tightly bound to serum proteins, and so has little access to glucocorticoid receptors in skin, eye, and bone, minimizing its risk of causing cutaneous thinning, cataracts, osteoporosis, or temporary slowing of growth. C-clesonide has been shown to be effective in improving asthma control in clinical trials, but studies have not yet proven that its use is associated with the significant reduction in systemic toxicity predicted from its design as a pro-drug with low corticosteroid activity, activated to a much more potent corticosteroid agonist by esterases at its site of deposition in the airways. Chronic use of inhaled corticosteroids effectively reduces symptoms and improves pulmonary function in patients with mild asthma. Such use also reduces or eliminates the need for oral corticosteroids in patients with more severe disease. In contrast to beta-stimulant agents and theophylline, chronic use of inhaled corticosteroids reduces bronchial reactivity. Because of the efficacy and safety of inhaled corticosteroids, national and international guidelines for asthma management recommend their prescription for patients who require more than occasional inhalations of a beta agonist for relief of symptoms. This therapy is continued for 10 to 12 weeks and then withdrawn to determine whether more prolonged therapy is needed. Inhaled corticosteroids are not curative. In most patients, the manifestations of asthma return within a few weeks after stopping therapy, even if they have been taken in high doses for 2 years or longer. A prospective, placebo-controlled study of the early, sustained use of an inhaled corticosteroids in young children with asthma showed significantly greater improvement in asthma symptoms, pulmonary function, and frequency of asthma exacerbations over the 2 years of treatment, but no difference in overall asthma control 3 months after the end of the trial. Inhaled corticosteroids are thus properly labeled as controllers. They are effective only so long as they are taken. Another approach to reducing the risk of long-term, twice-daily use of inhaled corticosteroids is to administer them only intermittently, when symptoms of asthma flare. Taking a single inhalation of an inhaled corticosteroid with each inhalation of a short-acting beta-agonist reliever, e.g., an inhalation of beclomethasone for each inhalation of albuterol, or taking a 5 to 10 day course of twice-daily high-dose budesonide or beclomethasone when asthma symptoms worsen has been found to be as effective as regular daily therapy in adults and children with mild to moderate asthma, although these approaches to treatment are neither endorsed by guidelines for asthma management nor approved by the FDA. Next we will discuss cromolyn and nedocromil. Cromolyn sodium, that is disodium chromoglycate, and nedocromil sodium were once widely used for asthma management, especially in children, but have now been supplanted so completely by other therapies that they are mostly of historic interest. Both have low solubility, are poorly absorbed from the gastrointestinal tract, and must be inhaled as a microfine powder or microfine suspension. When taken by inhalation, they effectively inhibit both antigen and exercise-induced asthma, and chronic use, 4 times daily, slightly reduces the overall level of bronchial reactivity. However, these drugs have no effect on airway smooth muscle tone and are ineffective in reversing asthmatic bronchospasm. They are only of value when taken prophylactically. Pause the video and carefully scrutinize the white box illustrating the structures of cromolyn sodium and nedocromil sodium before advancing to the next slide. We will now progress to the mechanism of action of cromolyn and nedocromil. Cromolyn and nedocromil are thought to alter the function of delayed chloride channels in the cell membranes, inhibiting cell activation. This action on airway nerves is thought to mediate nedocromil's inhibition of cough. On mast cells, the same mechanism is responsible for inhibition of the early response to antigen challenge, and on eosinophils, for inhibition of the inflammatory response to inhalation of allergens. The inhibitory effect on mast cells appears to be specific for cell type, since cromolyn has little inhibitory effect on mediator release from human basophils. It may also be specific for different organs, since cromolyn inhibits mast cell degranulation in human and primate lung but not in skin. This in turn may reflect known differences in mast cells found in different sites, as in their neutral protease content. At one time, The idea that cromolyn inhibits mast cell degranulation was so well accepted that the inhibition of a response by cromolyn was thought to indicate the involvement of mast cells in the response. This simplistic idea was overturned in part by the finding that cromolyn and nedocromyl inhibit the function of cells other than mast cells, and in part by the finding that nedocromyl inhibits appearance of the late response even when given after the early response to antigen challenge, i.e., after mast cell degranulation has occurred. And now we will discuss their clinical uses. In short-term clinical trials, pre-treatment with cromolyn or nedocromyl blocks the bronchoconstriction caused by allergen inhalation, by exercise, by sulfur dioxide, and by a variety of causes of occupational asthma. This acute protective effect of a single treatment makes cromolyn useful for administration shortly before exercise or before unavoidable exposure to an allergen. When taken regularly, 2 to 4 puffs 2 to 4 times daily, by patients with perennial, that is non-seasonal, asthma, both agents modestly but significantly reduce symptomatic severity and the need for bronchodilator medications, particularly in young patients with extrinsic asthma. These drugs are not as potent nor as predictably effective as inhaled corticosteroids, and the only way of determining whether a patient will respond is by a therapeutic trial of 4 weeks duration. Cromolyn and nedocromyl solutions are also useful in reducing symptoms of allergic rhinoconjunctivitis. Applying the solution by nasal spray or eye drops several times a day is effective in about 75% of patients, even during the peak pollen season. Because the drugs are so poorly absorbed, adverse effects of cromolyn and nedocromyl are minor and are localized to the sites of deposition. These include such minor symptoms as throat irritation, cough, and mouth dryness, and, rarely, chest tightness, and wheezing. Some of these symptoms can be prevented by inhaling a beta-2 adrenoceptor agonist before cromolyn or nedocromyl treatment. Serious adverse effects are rare. Reversible dermatitis, myositis, or gastroenteritis occurs in less than 2% of patients, and a very few cases of pulmonary infiltration with eosinophilia and anaphylaxis have been reported. This lack of toxicity accounts for cromolyn's formerly widespread use in children, especially those at ages of rapid growth. Its place in treatment of childhood asthma has lately diminished. However, because of the significantly greater efficacy of even low-dose corticosteroid treatment and because of the availability of an alternate non-steroidal controller class of medication, the leukotriene pathway inhibitors. We will now progress to leukotriene pathway inhibitors. Because of the evidence of leukotriene involvement in many inflammatory diseases and in anaphylaxis, considerable effort has been expended on the development of drugs that block the synthesis of these arachidonic acid derivatives or their receptors. Leukotrienes result from the action of 5-lipoxygenase on arachidonic acid and are synthesized by a variety of inflammatory cells in the airways, including eosinophils, mast cells, macrophages, and basophils. Leukotriene B4, abbreviated as LTB4, is a potent neutrophil chemoattractant, and LTC4 and limited-4 exert many effects known to occur in asthma, including bronchoconstriction, increased bronchial reactivity, mucosal edema, and mucus hypersecretion. Early studies established that antigen challenge of sensitized human lung tissue results in the generation of leukotrienes, whereas other studies of human subjects have shown that inhalation of leukotrienes causes not only bronchoconstriction, but also an increase in bronchial reactivity to histamine that persists for several days. Two approaches to interrupting the leukotriene pathway have been pursued. Inhibition of 5-lipoxygenase, thereby preventing leukotriene synthesis, and inhibition of the binding of limited 4 to its receptor on target tissues, thereby preventing its action. Efficacy in blocking airway responses to exercise and to antigen challenge has been shown for drugs in both categories: Xeluton, a 5-lipoxygenase inhibitor, and zafirlukast and montelukast, limited 4 receptor antagonists. All have been shown to improve asthma control and to reduce the frequency of asthma exacerbations in outpatient clinical trials. Their effects on symptoms, airway caliber, bronchial reactivity, and airway inflammation are less marked than the effects of inhaled corticosteroids, but they are more nearly equal in reducing the frequency of exacerbations. Their principal advantage is that they are taken orally. Some patients, especially children, comply poorly with inhaled therapies. Montelukast is approved for children as young as 6 years of age. Pause the video and carefully scrutinize the white box containing their structures before advancing to the next slide. Some patients appear to have particularly favorable responses, but no clinical features allow identification of responders before a trial of therapy. In the USA, Xeluton is approved for use in an oral dosage of 1,200 mg of the sustained release form twice daily, zafirlukast, 20 mg twice daily, and montelukast, 10 mg, for adults, or 4 mg, for children, once daily. Trials with leukotriene inhibitors have demonstrated an important role for leukotrienes in aspirin-induced asthma. It has long been known that 5 to 10% of asthmatics are exquisitely sensitive to aspirin, so that ingestion of even a very small dose causes profound bronchoconstriction and symptoms of systemic release of histamine, such as flushing and abdominal cramping. Because this reaction to aspirin is not associated with any evidence of allergic sensitization to aspirin or its metabolites, and because it is produced by any of the non-steroidal anti-inflammatory agents, it is thought to result from inhibition of prostaglandin synthetase, cyclooxygenase, shifting arachidonic acid metabolism from the prostaglandin to the leukotriene pathway. Support for this idea was provided by the demonstration that leukotriene pathway inhibitors impressively reduce the response to aspirin challenge and improve overall control of asthma on a day-to-day basis. Of these agents, Xeluton is the least prescribed because of reports of liver toxicity. The receptor antagonists appear to have little toxicity. Reports of Churg-Strauss syndrome, a systemic vasculitis accompanied by worsening asthma, pulmonary infiltrates, and eosinophilia, appear to have been coincidental, with the syndrome unmasked by the reduction in prednisone dosage made possible by the addition of zafirlukast or montelukast. Of these two, montelukast is the most prescribed, probably because it can be taken without regard to meals, and because of the convenience of once-daily treatment. And now we will focus on other drugs in the treatment of asthma. Let's begin with anti-IgE monoclonal antibodies. An entirely new approach to the treatment of asthma exploits advances in molecular biology to target IgE antibody. From a collection of monoclonal antibodies raised in mice against IgE antibody itself, a monoclonal antibody was selected that is targeted against the portion of IgE that binds to its receptors, Fc-epsilon-R1 and Fc-epsilon-R2 receptors, on mast cells and other inflammatory cells. Omalizumab, an anti-IgE monoclonal antibody, inhibits the binding of IgE to mast cells, but does not activate IgE already bound to these cells and thus does not provoke mast cell degranulation. The murine antibody has been genetically humanized by replacing all but a small fraction of its amino acids with those found in human proteins, and it does not appear to cause sensitization when given to human subjects. Administration of omalizumab to asthmatic patients for 10 weeks lowers plasma IgE to undetectable levels and significantly reduces the magnitude of both early and late bronchospastic responses to antigen challenge. Repeated administration lessens asthma severity and reduces the corticosteroid requirement in patients with moderate to severe disease, especially those with a clear environmental antigen precipitating factor, and improves nasal and conjunctival symptoms in patients with perennial or seasonal allergic rhinitis. Omalizumab's most important effect is reduction of the frequency and severity of asthma exacerbations, even while enabling a reduction in corticosteroid requirements. Combined analysis of several clinical trials has shown that the patients most likely to respond are, fortunately, those with the greatest need. Those with a history of repeated exacerbations, a high requirement for corticosteroid treatment, and poor pulmonary function. Similarly, the exacerbations most prevented are the ones most important to prevent. Omalizumab treatment reduced exacerbations requiring hospitalization by 88%. These benefits justify the high cost of this treatment in selected individuals with severe disease characterized by frequent exacerbations. Next we will discuss possible future therapies. The rapid advance in the scientific description of the immunopathogenesis of asthma has spurred the development of many new therapies targeting different sites in the immune cascade. These include monoclonal antibodies directed against cytokines, such as IL-4, IL-5, and IL-13, antagonists of cell adhesion molecules, protease inhibitors, and immunomodulators aimed at shifting CD4 lymphocytes from the Th2 to the Th1 phenotype or at selective inhibition of the subset of Th2 lymphocytes directed against particular antigens. There is evidence that asthma may be aggravated, or even caused, by chronic airway infection with Chlamydia pneumoniae or Mycoplasma pneumoniae. This may explain the reports of benefit to some patients from treatment with macrolide antibiotics, but a recent trial of prolonged treatment with clarithromycin dosed at 500 mg twice daily for weeks failed to improve asthma control in patients with moderately severe asthma. Next we will consider the clinical pharmacology of drugs used in the treatment of asthma. Asthma is best thought of as a disease in two time domains. In the present domain, it is important for the distress it causes, cough, nocturnal awakenings, and shortness of breath that interferes with the ability to exercise or to pursue desired activities. For mild asthma, occasional inhalation of a bronchodilator may be all that is needed. For more severe asthma, treatment with a long-term controller, like an inhaled corticosteroid, is necessary to relieve symptoms and restore function. The second domain of asthma is the risk it presents of future events, such as exacerbations, or of progressive loss of pulmonary function. A patient's satisfaction with his or her ability to control symptoms and maintain function by frequent use of an inhaled beta-2 agonist does not mean that the risk of future events is also controlled. In fact, use of 2 or more canisters of an inhaled beta agonist per month is a marker of increased risk of asthma fatality. The challenges of assessing severity and adjusting therapy for these two domains of asthma are different. For relief of distress in the present domain, the key information can be obtained by asking specific questions about the frequency and severity of symptoms, the frequency of use of an inhaled beta-2 agonist for relief of symptoms, the frequency of nocturnal awakenings, and the ability to exercise. Estimating the risk for future exacerbations is more difficult. In general, Patients with poorly controlled symptoms in the present have a heightened risk of exacerbations in the future, but some patients seem unaware of the severity of their underlying airflow obstruction, sometimes described as poor perceivers, and can be identified only by measurement of pulmonary function, as by spirometry. Reductions in the forced expiratory volume in 1 second, abbreviated as FEV1, correlate with heightened risk of attacks of asthma in the future. Other possible markers of heightened risk are unstable pulmonary function, large variations in forced expiratory volume in 1 second from visit to visit, large change with bronchodilator treatment, extreme bronchial reactivity, or high numbers of eosinophils in sputum or of nitric oxide in exhaled air. Assessment of these features may identify patients who need increases in therapy for protection against exacerbations. We will now shift gears to bronchodilators. Bronchodilators, such as inhaled albuterol, are rapidly effective, safe, and inexpensive. Patients with only occasional symptoms of asthma require no more than an inhaled beta-2 receptor agonist taken on an as-needed basis. If symptoms require this, rescue therapy more than twice a week, if nocturnal symptoms occur more than twice a month, or if the forced expiratory volume in 1 second is less than 80% predicted, additional treatment is needed. The treatment first recommended is a low dose of an inhaled corticosteroid, although treatment with a leukotriene receptor antagonist or with cromolyn may be used. Theophylline is now largely reserved for patients in whom symptoms remain poorly controlled, despite the combination of regular treatment with an inhaled anti-inflammatory agent and as needed use of a beta-2 agonist. If the addition of theophylline fails to improve symptoms or if adverse effects become bothersome, it is important to check the plasma level of theophylline to be sure it is in the therapeutic range, that is 10 to 20 mg per liter. An important caveat for patients with mild asthma is that although the risk of a severe, life-threatening attack is lower than in patients with severe asthma, it is not zero. All patients with asthma should be instructed in a simple action plan for severe, frightening attacks, to take up to 4 puffs of albuterol every 20 minutes over 1 hour. If they do not note clear improvement after the first 4 puffs, they should take the additional treatments while on their way to an emergency department or some other higher level of care. We will now focus on muscarinic antagonists. Inhaled muscarinic antagonists have so far earned a limited place in the treatment of asthma. The effects of short-acting agents, e.g., ipratropium bromide, on baseline airway resistance is nearly as great as, but no greater than, those of the sympathomimetic drugs, so they are used largely as alternative therapies for patients intolerant of beta-2 adrenoceptor agonists. The airway effects of antimuscarinic and sympathomimetic drugs given in full doses have been shown to be additive only in patients with severe airflow obstruction who present for emergency care. The long-acting antimuscarinic agent tiotropium has not yet earned a place in the treatment for asthma, although it has been shown to be as effective as a long-acting beta-2 agonist when used in addition to an inhaled corticosteroid treatment for that condition. As a treatment for chronic obstructive pulmonary disease, tiotropium both improves functional capacity, presumably through its action as a bronchodilator, and reduces the frequency of exacerbations, through mechanisms not yet defined. Although it was predicted that muscarinic antagonists would dry airway secretions and interfere with mucociliary clearance, direct measurements of fluid volume secretion from single airway submucosal glands in animals show that atropine decreases baseline secretory rates only slightly. The drugs do, however, inhibit the increase in mucus secretion caused by vagal stimulation. No cases of inspissation of mucus have been reported following administration of these drugs. And now let's look at corticosteroids. If asthmatic symptoms occur frequently or if significant airflow obstruction persists despite bronchodilator therapy, inhaled corticosteroids should be started. For patients with severe symptoms or severe airflow obstruction, e.g., forced expiratory volume in 1 second less than 50% predicted, initial treatment with a combination of inhaled and oral corticosteroid, e.g., 30 mg per day of prednisone for 3 weeks, is appropriate. Once clinical improvement is noted, usually after 7 to 10 days, the oral dose should be discontinued or reduced to the minimum necessary to control symptoms. An issue for inhaled corticosteroid treatment is patient adherence. Analysis of prescription renewals shows that corticosteroids are taken regularly by a minority of patients. This may be a function of a general steroid phobia, fostered by emphasis in the lay press on the hazards of long-term oral corticosteroid therapy and by ignorance of the difference between corticosteroids and anabolic steroids, taken to enhance muscle strength by now infamous athletes. This fear of corticosteroid toxicity makes it hard to persuade patients whose symptoms have improved after starting treatment that they should continue it for protection against attacks. This context accounts for the interest in reports that instructing patients with mild but persistent asthma to take inhaled corticosteroid therapy only when their symptoms worsen is as effective in maintaining pulmonary function and preventing attacks as is taking the inhaled corticosteroid twice each day. See above. In patients with more severe asthma whose symptoms are inadequately controlled by a standard dose of an inhaled corticosteroid, 2 options may be considered: to double the dose of inhaled corticosteroid or to combine it with another drug. The addition of theophylline or a leukotriene receptor antagonist modestly increases asthma control, but the most impressive benefits are noted from addition of a long-acting inhaled beta-2 receptor agonist, salmeterol or formoterol. Many studies have shown this combination therapy to be more effective than doubling the dose of the inhaled corticosteroid for reducing symptoms, reducing the, as needed, use of albuterol, and preventing attacks of asthma. Combinations of an inhaled corticosteroid and a long-acting beta agonist in a single inhaler are now commonly prescribed, e.g., fluticasone and salmeterol, marketed as Advair, budesonide and formoterol, marketed as Symbicort. Offsetting the clear benefits is evidence of a statistically significant increase in the very low risk of fatal asthma attacks from use of a long-acting beta agonist, perhaps even when taken in combination with an inhaled corticosteroid. This evidence prompted the FDA to issue a black box warning that the use of a long-acting beta agonist is associated with a small but statistically significant increase in the risk of death or near death from an asthma attack, especially in African Americans. The FDA did not withdraw approval of these drugs, for it recognizes that they are clinically effective. The major implications of the black box warning for the practitioner are: 1. That patients with mild to moderate asthma should be treated with a low-dose inhaled corticosteroid alone, and additional therapy considered only if their asthma is not well controlled. And 2. That if their asthma is not well controlled, the possible increase in risk of a rare event, asthma fatality, should be discussed in presenting the options for treatment, an increase to a higher dose of the inhaled corticosteroid versus addition of a long-acting beta agonist. The FDA's warning has not so far had much effect on prescriptions for combinations of an inhaled corticosteroid with a long-acting beta agonist, probably because their combination in a single inhaler offers several advantages. Combination inhalers are convenient. They ensure that the long-acting beta agonist will not be taken as monotherapy, known not to protect against attacks, and they produce prompt, sustained improvements in clinical symptoms and pulmonary function and reduce the frequency of exacerbations requiring oral corticosteroid treatment. In patients prescribed such combination treatment, it is important to provide explicit instructions that a rapid-acting inhaled beta-2 agonist, such as albuterol, should be used as needed for relief of acute symptoms. An emerging approach to treatment takes advantage of the rapidity of onset of the bronchodilator action of the long-acting beta agonist formoterol delivered in fixed-dose combination with the inhaled corticosteroid budesonide in Symbicort metered dose inhalers. Several studies have confirmed that twice-daily and as-needed inhalation of this combination is as effective in preventing asthma exacerbations as a 4 times higher dose of budesonide twice daily with only albuterol for relief of symptoms. Use of this flexible dosing strategy is widespread in Europe, but is not approved in the USA. And now we will consider the leukotriene antagonists, cromolyn and nedocromil. A leukotriene receptor antagonist taken as an oral tablet may be considered as an alternative to inhaled corticosteroid treatment in patients with symptoms occurring more than twice a week or those who are awakened from sleep by asthma more than twice a month. This place in asthma therapy was once held by cromolyn and nedocromil, but neither is now available in the USA. Although these treatments are not as effective as even a low dose of an inhaled corticosteroid, both avoid the issue of steroid phobia, described above, and are commonly used in the treatment of children. The leukotriene receptor antagonist montelukast, singular, is widely prescribed, especially by primary care providers. This drug, taken orally, is easy to administer and appears to be used more regularly than inhaled corticosteroids. Leukotriene receptor antagonists are rarely associated with troublesome side effects. Because of concerns over the possible long-term toxicity of systemic absorption of inhaled corticosteroids, this maintenance therapy is widely used for treating children in the USA. Next we will look at anti-IgE monoclonal antibody. Treatment with omalizumab, the monoclonal humanized anti-IgE antibody, is reserved for patients with chronic severe asthma inadequately controlled by high-dose inhaled corticosteroid plus long-acting beta-agonist combination treatment, e.g., fluticasone, 500 micrograms, plus salmeterol, 50 micrograms, inhaled twice daily. Omalizumab reduces lymphocytic, eosinophilic bronchial inflammation and effectively reduces the frequency and severity of exacerbations. It is reserved for patients with demonstrated IgE-mediated sensitivity by positive skin test or radioallergen sorbent test, abbreviated as RAST, to common allergens, and an IgE level within a range that can be reduced sufficiently by twice-weekly subcutaneous injection. And now we will discuss other anti-inflammatory therapies. Some reports suggest that agents commonly used to treat rheumatoid arthritis may also be used to treat patients with chronic steroid-dependent asthma. The development of an alternative treatment is important, because chronic treatment with oral corticosteroids may cause osteoporosis, cataracts, glucose intolerance, worsening of hypertension, and Cushingoid changes in appearance. Initial studies suggested that oral methotrexate or gold salt injections were beneficial in prednisone-dependent asthmatic patients, but subsequent studies did not confirm this promise. In contrast, the benefit from treatment with cyclosporine seems real. However, This drug's great toxicity makes this finding only a source of hope that other immunomodulatory therapies will ultimately be developed for the small proportion of patients whose asthma can be managed only with high oral doses of prednisone. An immunomodulatory therapy recently reported to improve asthma is injection of etanercept, a TNF-alpha antagonist used in the treatment of ankylosing spondylitis and severe rheumatoid arthritis. We will now briefly discuss the management of acute asthma. The treatment of acute attacks of asthma in patients reporting to the hospital requires close, continuous clinical assessment and repeated objective measurement of lung function. For patients with mild attacks, inhalation of a beta-2 receptor agonist is as effective as subcutaneous injection of epinephrine. Both of these treatments are more effective than intravenous administration of aminophylline, a soluble salt of theophylline. Severe attacks require treatment with oxygen, frequent or continuous administration of aerosolized albuterol, and systemic treatment with prednisone or methylprednisolone, dosed at 0.5 mg per kilogram every 6 to 12 hours. Even this aggressive treatment is not invariably effective, and patients must be watched closely for signs of deterioration. General anesthesia, intubation, and mechanical ventilation of asthmatic patients cannot be undertaken lightly, but may be life-saving if respiratory failure supervenes. Next we will discuss the prospects for prevention of asthma. The high prevalence of asthma in the developed world and its rapid increases in the developing world call for a strategy for primary prevention. Strict antigen avoidance during infancy, once thought to be sensible, has now been shown to be ineffective. In fact, growing up from birth on a farm with domestic animals or in a household where cats or dogs are kept as pets appears to protect against developing asthma. The best hope seems to lie in understanding the mechanisms by which microbial exposures during infancy foster development of a balanced immune response, and then mimicking the effects of natural environmental exposures through administration of harmless microbial commensals, that is probiotics, or of nutrients that foster their growth, that is prebiotics, in the intestinal tract during the critical period of immune development in early infancy. And now let's consider the treatment of chronic obstructive pulmonary disease, abbreviated as COPD. Chronic obstructive pulmonary disease is characterized by airflow limitation that is not fully reversible with bronchodilator treatment. The airflow limitation is usually progressive and is believed to reflect an abnormal inflammatory response of the lung to noxious particles or gases. The condition is most often a consequence of prolonged habitual cigarette smoking, but approximately 15% of cases occur in non-smokers. Although chronic obstructive pulmonary disease is different from asthma, some of the same drugs are used in its treatment. This section discusses the drugs that are useful in both conditions. Although asthma and chronic obstructive pulmonary disease are both characterized by airway inflammation, reduction in maximum expiratory flow, and episodic exacerbations of airflow obstruction, most often triggered by viral respiratory infection, they differ in many important respects. Most important among them are differences in the populations affected, characteristics of airway inflammation, reversibility of airflow obstruction, responsiveness to corticosteroid treatment, and course and prognosis. Compared to asthma, chronic obstructive pulmonary disease occurs in older patients, is associated with neutrophilic rather than eosinophilic inflammation, is poorly responsive even to high-dose inhaled corticosteroid therapy, and is associated with progressive, inexorable loss of pulmonary function over time, especially with continued cigarette smoking. Despite these differences, the approaches to treatment are similar. although the benefits expected and achieved are less for chronic obstructive pulmonary disease than for asthma. For relief of acute symptoms, inhalation of a short-acting beta agonist, e.g., albuterol, of an anticholinergic drug, e.g., ipratropium bromide, or of the two in combination is usually effective. For patients with persistent symptoms of exertional dyspnea and limitation of activities, regular use of a long-acting bronchodilator, whether a long-acting beta agonist, e.g., salmeterol, or a long-acting anticholinergic, e.g., tiotropium, is indicated. For patients with severe airflow obstruction or with a history of prior exacerbations, regular use of an inhaled corticosteroid reduces the frequency of future exacerbations. Theophylline may have a particular place in the treatment of chronic obstructive pulmonary disease, as it may improve contractile function of the diaphragm, thus improving ventilatory capacity. The major difference in treatment of these conditions centers on management of exacerbations. The use of antibiotics in this context is routine in chronic obstructive pulmonary disease, because such exacerbations involve bacterial infection of the lower airways far more often in chronic obstructive pulmonary disease than in asthma. Pause the video and carefully scrutinize this table, which is a summary of drugs used in asthma, before advancing to the next slide. Pause the video and carefully scrutinize this table, which is a summary of drugs used in asthma, before advancing to the next slide. Pause the video and carefully scrutinize this table, which is a summary of preparations available, before advancing to the next slide. Pause the video and carefully scrutinize this table, which is a summary of preparations available, before advancing to the next slide. Thank you.